I hope you can all hear me. Thank you for joining us today on this topic of virtual consultations, some of which we've already alluded to in the previous session that we've had. We've got four speakers who are going to be talking to us, and we're going to go through all the talks before going on to the questions at the end, if that's okay. I'd like to introduce Alka Ahuja and Gemma Johns, who both work at the Welsh Technology Enablement Group. Alka is the clinical lead, and Gemma is the research lead and evaluation lead for that group. That will be followed by a talk by Greg Nichols, who's a GP with a special interest in MSK problems, who has been working in Scotland to develop virtual consultations for primary care. And then we will finally have a talk by Dermot Ferguson, who's the president of the National Council for Back Pain, National Back Pain Council, and he is going to be talking about the use of virtual consultations in the spinal setting. So if we could please move on to the first talk by Alka Ahuja and Gemma Johns, please.
Hello everybody. Thank you for giving us an opportunity to share the work we have been doing with the National Video Consulting Service in Wales. I'm Alka Ahuja, I'm the National Clinical Lead.
Hi, and I'm Gemma Johns, the Research and Evaluation Lead for Tech Cymru.
So as you may have guessed, we are both Gavin and Stacey fans, so talking about what's occurring in Wales. Starting with the National Video Consultation Service and what COVID brought along, then moving on to specifically talking about video consultation in musculoskeletal clinics, what the data shows, and how we move forward with this. So the National Video Consultation Service is funded by Welsh Government, and it is to deliver safe and timely care across health and social care settings. It's in line with Healthier Wales, which brings care closer to home and provides a chance for people to have choice about their health and well-being. Tech Cymru, which is technology-enabled care, is hosted by Aaron Bevan University Health Board, and Kuch, which was our health foundation project connecting with telehealth to children in hospital, was used as an exemplar by Welsh Government while rolling out the national service. We have been using Attend Anywhere as the uniform platform across Wales. So when COVID came along last year, Welsh Government decided to roll out video consultation so that we could continue to provide care to the people in Wales, but also protecting our workforce. We started with primary care and then swiftly moved into all other services across the country. Almost 90% of GP surgeries went live within a couple of weeks, and as of now, we've done more than 13,000 consultations, including out of hours and the 111 service. The codes at the bottom are some of the codes provided by our clinicians and patients who have been part of our evaluation journey. We then, Easter weekend, moved into secondary and community care, and each health board used their own secondary prioritization tool to decide which services go live first. And not surprisingly, there was a lot of common services highlighted by them, including the COVID wards, palliative care, hospices, frailty, hematology, intensive care, which again, was not surprising. Therapy seemed to have embraced it, and moving forward into the future, this is one service which will continue to use video consulting and has found it beneficial from clinician and patient point of view. Mental health, again, surgical specialties, especially colorectal and urology, were very forthcoming when the rollout initially started, and there has been evidence of them working in these practices pre-COVID as well. So as of date, we've rolled out to more than 50 specialties and services and done more than 130,000 consultations. And currently we're doing about 5,000 video consultations a week. The other settings were care homes, not surprisingly, where the most vulnerable and fragile people were residing, so as to enable regular contact with their GP practices, ward rounds, hospital appointments, schools, the Welsh Ambulance Service, dentistry, optometry, pharmacy. And in the last few weeks, we've been working on virtual visiting, which has enabled a lot of patients who have been inpatients in the hospital to have contact with their loved ones, but also provided the staff on the ward along with the therapist to get to know the family and to plan discharge so that when these people are sent home, the adequate equipment and care can continue to be provided in the home setting. We've been running virtual groups for more than 5 years, and although these were mainly restricted to children and young people, they have included groups from speech and language therapists, dietitians, educational psychologists, physiotherapists, but in post-COVID, we know with social restriction and isolation, these groups will not continue to happen the way they were happening in community centers and leisure centers. So thinking of running virtual groups in the new normal, especially with the need for rehab groups, physio groups, oncology groups, speech and language groups, and this has also provided an opportunity to partner with social services, third sector, and colleagues in education. We've been very mindful whatever we do in terms of video consultation, we gather the evidence. So from day one, we've got a robust evaluation framework based on quality improvement, mixed methodology, and Gemma will talk more about it in her section. Our phase 1 was involving surveys from clinician and patient end so that we could capture the experience and satisfaction of people using video consulting. And of date, we've had more than 37,000 responses. We then started with phase 2 in summer last year, which was capturing measures around benefits, challenges, and sustainability, and started doing qualitative in-depth interviews, and so far have interviewed more than 500 clinicians, patients, and carers. We are now in phase 3, where we're looking at capturing efficacy and effectiveness, looking at how video consultation compares to face-to-face. Does it take more time? Is it less? Which patients it's suitable, which patients it wouldn't be suitable, because we want to get a better understanding if we want to embed it and make it sustainable in the future. Just to highlight some of our findings from the evaluation, as I mentioned, we've done more than 137 patient consultation, dealing with 37,000 responses from our surveys and 437 interviews. In terms of reduction in travel time, cost, and carbon footprint, the savings have been amazing. And one thing that has been a common feedback from patients and clinicians has been the need to travel less and the stress of finding a place to park. Again, it's enabled patients to have consultation from their home environment, but also to protect the workforce and provide a home life balance for a lot of clinicians. In terms of demographics, we've seen our elderly, 21% of our above 65 have embraced this new way of delivering care, and 92% of patients have rated the service as excellent and very good. So what would the new normal be moving forwards as we come out of COVID? Literature just shows that clinicians have concerns, especially in musculoskeletal settings where there is a need for physical examination. And in order to increase their confidence level, it may be thinking about a standardized method of doing remote assessments for spinal disorders. There's a recent study which shows that follow-up appointments resulted in decreased time spent on traveling and also savings for both clinicians and patients. In terms of comparison of face-to-face with video consulting, there's consistently high levels of patient satisfaction and agreement for diagnosis, as reported in a pre-COVID study. And also there has been a recent study showing the use of video consultation for preoperative assessments. What we have realized as a part of our evaluation is the patient choice and the empowerment that it provides and the opportunity to engage much better with our patients while giving them the opportunity to have this way of accessing health and care. I'll pass over to Gemma.
Yeah, so video consulting here in Wales, like Alka said, has been done over 137,000 video consulting so far. Interestingly, only 21% of these are falling within mental health consultations, and in that the largest percentage of video consultations are now within physical health and in therapies. So Tech Cymru have been collecting mixed methods data, and as Elka said, we've collected more than 37,000 responses from patients and professionals. So so far we've got a really good understanding of both voices. So we did a simple extraction of this data so we could have a bit of an understanding of the data across MSK. obviously was only simple extractions. We've only been able to pull people who have specifically put it into this category. So we have 922 participants to look at, but when we do a proper analysis of it, we'll have a better understanding, but we wanted something to show today. So as you can see, the patient demographics are quite varied across this sample group, and again, in the older age groups as well. Fair distribution against gender, and it was almost 20% of them reported a disability. So already you can see a benefit for them to be able to be from home. Another one of the questions was what type of specialist this was with. So just under 80% of them were with therapists within MSK, and just under 20% were doctors and consultants. So we have been capturing the quality of the video consultation by asking questions around satisfaction. Interestingly, in this sample group, there's a 20% difference between satisfaction reported by patients and compared to those reported by clinicians. And this is quite different to the rest of our data, which tends to have about a 10% difference. So this was quite interesting when we pulled this. But as you can see, still high satisfaction, but the majority, 94%, sits with patients, with 66% of clinicians reporting it as excellent, very good, or good. So whilst more analysis is needed in this, and we do need to dig a lot deeper, we wanted to pull out a few other measures to sort of explore today and help understand this a little better. So we had a look at the video consultation appointment types to see if there was any difference there. The patients who are in the blue, they tend to be majority in the therapy and treatments, how they refer to their appointment type, compared to the clinicians who are the purple, who seem to be the highest in first-time appointments and lowest in reviews and follow-ups. There could be something there to depend on maybe the appointment type might determine satisfaction differently. However, first appointment slightly varies as well between that and the patient and the clinician. So it also might be a definition difference, and maybe how a patient defines an appointment type might actually be a bit different to how a clinician does purely by definition, not necessarily by satisfaction. But again, this will need more to understand it. But I think it's quite interesting maybe to think that higher satisfaction might be more dependent on the type of appointment, and maybe higher satisfied in maybe therapies such as with the physiotherapist. Another question we asked was, did this video consulting prevent a face-to-face needed? Interestingly, more clinicians said yes compared to patients. So 86% of clinicians reported a face-to-face prevention compared to 62% of patients. Yet, interestingly, still lower satisfaction among clinicians. So we wanted to look at some other measures to see if these were any more influences on the rating of satisfaction. And as you can quite clearly see, challenges from clinicians, which are reported in the purple, are much, much higher than that they are in patients. So we could easily assume that challenges of using the device based on things like internet connectivity, video, audio, or the lack of confidence, or not that they just believe it's not clinically suitable, may seem to be impacted on whether or not they rate in high satisfaction. And as you can see, they are much higher than they are in patient groups. However, interestingly, the preference for face-to-face is quite equal, and with 21% of clinicians and 22% of patients reporting they prefer a face-to-face compared to VC, but that is almost 80% still happy with the video consulting. And again, we ask questions around benefits of video consulting. And again, here you can see that benefits in the green, which are the patients, are slightly higher than that of the clinicians. So perhaps you could assume here that the benefits may be a determining factor on satisfaction, higher, which has been higher reported by patients. And as you can see, these benefits are very higher for patients, but both patients and for clinicians in save time and preparation, travel and parking, environment, having time off work and school was 58% for patients, money savings 60%, improved family support, reduced stress and anxiety, Improved access to care was rated quite high by both clinicians and patients, 83% for patients, 70% for clinicians. Reduced waiting time was 53%, reported only by clinicians, and reduced likelihood of DNAs of 41% of the time by clinicians. So a wide range of benefits, really. So here's a few quotes from the patients, and this was just a few out of hundreds of wonderful quotes. And patients are consistently saying what a progressive system video consulting is, how this should be embedded into routine practice moving forward, and how fantastic the service is, and then amount of benefits they get put out, things like independent care and how this allows them to take care of themselves within their own home and not having to depend on anyone else to take them to an appointment. And how easy and straightforward the platform is, how it's saved on preparation and travel, how they believe it's put less risk on their own health, and other benefits such as not having to get childcare to attend an appointment in person. So moving forward, as you can see in the sort of in the data that we've got, is quite limited in numbers, and at the moment it's only 922, and spinal specific data is quite limited within this data set, especially from clinicians. So we were very keen to explore this further. So we've been conducting interviews with spinal teams in Wales, and we've been able to capture some really exciting developments going forward, particularly that in spinal surgeons using video consulting. So we've also been working with spinal teams here in Wales to develop a home working guide. So we're combining benefits and challenges of home working whilst using video consulting. And we developed a how-to guide to protect both your mental health, your well-being, and your physical health. So we've been sort of step-by-step guides of how to protect your back, your neck, your shoulders whilst working from home and making sure you've got a proper setup. We've also, in partnership with spinal teams across the UK, so we're developing a guideline at the moment with a tertiary team in Wales, secondary care team in England, and a primary care team in Scotland. And with this team, we're also running a webinar on video consulting and the spine on the 17th of March. So you can follow this link here if you would like to register and join us. And we're also, like Elke said, starting some efficacy work at the moment. And we've just started a case control study where we're comparing video consulting with in-person appointments for the use of triage for spinal surgery. So it's all very exciting. And in the year that we've been conducting this, we have got, we've started to get a much better understanding of VC as a whole, VC in MSK, and VC now in spinal. And as you can see, we're very keen here in tech to make sure that we get the voices of all users of any technology approach that we use. We are very keen to make sure we get the professional and patient perspective throughout everything we capture. And as you can see, patients for video consulting, for example, are very, very keen to use it. They really do see the benefits of using it. And I think going forward, we have to make sure that we're always making sure we look after what the patients need as well. And that's embedded in everything we do here in Tech Cymru and all the evaluation we do. So thank you very much. And if you have any other questions about the research that we're doing or our evaluation approaches, please email us with the contacts below.
Thank you for inviting me today to speak at the conference. My name's Greg Nichol, and I'm a GP with special interest in orthopaedics working in NHS Grampian. I'm going to talk today about how we developed a remote MSK assessment guide in COVID and some of the challenges that we faced that are hopefully going to be relevant for you. I took over initially from two of the previous GP with special interest who worked half a day a week each, and over time we've developed a good relationship with several of the surgeons so that I can work closely and, if necessary, on conclusion of a conservative or non-surgical treatment, can list patients for surgery, whether it be arthroplasty or other procedures. If I need to, I can refer them for bone scans, MRI, X-ray, obviously, and see them back with the results and either get them back to perform injections or refer on for injections to be performed by someone else. I looked to do a bit more though. I was keen to expand my work in orthopaedics, and spoke with management and the clinical lead at the time and said, I'd like to work more. And they said it might be useful if, rather than just more clinics, if you would think about looking at some ways to help work on our, at the time, very long waiting times, and maybe reduce the referrals coming in the way and try and collaborate better with primary care. So I started a second role within the orthopaedic department, working initially on pathways to make it easier to make accurate referrals from primary care to secondary care. We analysed some data and found that about 65% of all referrals didn't seem to need a surgeon appointment to begin with. That was covering half of the population of Aberdeen for hip, knee and shoulder referrals and part of Aberdeenshire. So it was 1,000 knee referrals, giving us a good indication that there was a role for non-surgical staff to be seeing some of the work that comes in. So we tried to smooth the pathway there to make it easier to see the right people. Worked on some educational sessions, so some of those were delivered in the practice, so going to practices that had traditionally found it difficult to attend teaching in Aberdeen, some rural practices, some with staff, high staff turnovers, able to go out at lunchtime and deliver bespoke training opportunities, and larger sessions as well. We've hired big venues with good attendances of upwards of 50 attendees locally. And one of our biggest ones was our spine event, when we had a huge number of speakers, including a rheumatologist, a pain consultant, acupuncturist, a yoga teacher, chiropractor, a spinal surgeon, an osteopath, physiotherapist. I talked at it as well. So try to keep these things very interesting and trying to optimise the engagement and the interest from primary care. This is hoping to upskill my colleagues in primary care to build their confidence, build their skills, keep them updated of changes in practice and changes in evidence. And when the referrals come in, we are then able to have a good rapport whereby we can get back to the referrer if we need to, organise scans in advance of the appointment, and potentially send some referrals back to the GP or other referrer with guidance on how best to work without the need to wait for an outpatient appointment. On looking at the subsequent vetting that we did in post, this was my own vetting, that the blue pie segment there, just under 20% of referrals went straight to an orthopaedic surgeon. The rest were suitable and were dealt with by either physiotherapists, 20% back to the referrer, and over 50% were dealt with by me at the GP with Special Interest Clinic. We're currently going through the outcomes of those appointments now to nail down the data further. Lots of clinics with 80 and 100% conversion to surgery because the surgeons are not seeing the non-surgical cases. And certainly increasing role of GP with special interest, with my colleague also working here now, low cases of re-referral for those that were sent back to referrer. So things seem to be working well. Initially, patients stayed at home. That was the guidance to begin with in the first lockdown, and I think patients were happy to buy in and collaborate with us there to say that they would stay at home so that they didn't find that their knee was sore when they played football, that they didn't find that their back was sore at work. So referrals definitely plummeted. Our referrals went down dramatically. But then the lockdown was extended, and GPs were encouraged to work remotely in some novel ways for some practices. Video, e-consult and phone referrals were certainly pushed locally, with the public being aware that their first appointment and indeed their entire treatment might be carried out by e-consult or even on the phone, maybe with a face-to-face. Inconsistencies of the quality of the referrals that were coming in. So we found that although there was an inconsistency going on there, many of the examinations we were doing again and again in much the same way, but we still felt as though we were improvising or trying to create a reinvention of the wheel every time we did a knee or a hip examination. And we wanted something to refer to that was useful for us, useful for colleagues, and useful for those in secondary care too. In our unique role sitting between primary and secondary care, we wondered how we could improve the situation. And we felt that we could refer to some of the information that we gleaned from the referrals that we'd looked at in the preceding year. Now, this was pre-COVID. Did we send it back to the referrer? Did we have to include imaging? Lots to go on there. But in amongst those, there's two in blue that include some of the softer sides. And these were some of the, if you like, the educational needs, the bits that were deficient even pre-COVID. And these allowed us to make a realistic assessment of what was likely to be feasible and what was likely to be the educational need of our colleagues if we're going to provide something to help with remote work. So we decided to create an examination guide. Initially, the thought was to drip feed this out to primary care colleagues, but there was a need for something at the time because we could receive referrals were starting to come in, and these were very difficult to manage because from a remote telephone or video appointment, some referrers just didn't know what to do. The main thing that we tapped into, first of all, was our own experience of our mistakes, the things that we did well and the things that we didn't do well, the ways that we examined hips again and again and found that they worked and found that they didn't work, the cues that we gave patients, and we realised it just made things more complicated. So there was lots to learn from our experience and that of our colleagues. We obviously did the requisite reading around the many articles that started to appear about MSK and other assessment, and we've been on plenty of webinars to observe other people's ideas here too. We collaborated closely with colleagues in primary care as to what they felt was feasible as we produced the guide, and went to our consultant colleagues to say, were these outcomes likely to be useful for what you could do with a referral? We wanted to tie the outcomes of the examination into a meaningful referral letter or the capacity to care in primary care. So we wanted to tap it into an existing resource called Grampian Guidance. This is available on the intranet in NHS Grampian. This is intended as something that primary care can use as a resource to guide assessment and then ultimately to refer to the right place if that was necessary. When it came to putting together our examination guide, we wanted this to be realistic. So we wanted to make it that it was intuitive and it was trying to get some of the same outcomes, tying in with the COVID context, but also being realistic as to what we could achieve in primary care via video. We wanted it to be valid as far as was possible with these examination and assessment tools. We wanted it to be easy to use, not just for those of us like us who were passionate about musculoskeletal, but also those who have no interest or active disinterest in musculoskeletal. And for those who felt that a patient with a sore knee generally required a referral to orthopaedics, we wanted to give them the tools to make a good assessment and then instigate treatment in a more effective way. Time was of the essence too, so we wanted to produce it in a timely way and get it out there while COVID was really dominating our lives. And we wanted it to be dynamic so that we could add to it, we could take away, and we could improve it as time went on. And it was important for us to have a shared understanding of the content, so both primary and secondary care were able to know what we were putting in, what the intention was, and what was the guide that we were basing the assessment on. So this is our examination guide that we disseminated with primary care, and we shared it with colleagues that we knew well, and we also shared it widely within the whole of the NHS Grampian intranet. We used ourselves as models, and hence the lack of glamour that's going on there and the hairy legs and hairy backs. We hopefully tried to keep it in a fairly simple and structured way. So we initially started with setup because we realised that the commonest mistakes were those when we hadn't set up properly. We hadn't got the camera in the right position. We hadn't told the patient what was going to be happening. We put down some guidance here for primary care as to what to do, because quite often what we would do is to speak to the patient on the phone and then say, in 20 minutes, half an hour, we'll book you in for the near me appointment if you check in. And if you tell me the device, here's how we're going to set up your device. It'll be nice to speak to you face to face, but then after a while, say it's a knee examination, we're going to get you to put the camera on the floor. And when the camera's on the floor, we'll be able to examine you well. So we can talk the patient through the IT facilities, the placement, where they should stand, and then demonstrating that what you can see on your camera is what I can see on my camera. Asking the patient to copy what you're going to do. All these things seem to be common sense now, I think, but at the time, it was really quite challenging to actually know what to say to patients to get them to do what you're asking them to do. Getting them set up with the correct clothes in advance was also useful, and to try and minimise non-verbal and verbal cues, particularly when it comes to doing the examination part. So for instance, we would then look to do, if we were doing our shoulder examination in our guides, the GP's got this on their desktop, they can rule out the red flags, a wee reminder about how to get the patient into the correct position and to examine the neck. We thought it would be good to use a kind of anatomical type approach because that makes possibly more intuitive sense to those in primary care and ties in with our Grampian guidance. So going through here in terms of the subacromial space with some hopefully fairly clear pictures on how to do an examination. Targeting exactly what we're talking about with an AC joint, talk through some of the tests that we can do, And again, all the photos taken as if to demonstrate, here's what you can ask the patient to do on camera. Make your camera look like this. Trying to make it really clear, this is not going to be a perfect examination of external rotation. We're not looking at everything at the same time. We can't go around the back of the patients, but we can make the beginnings of an assessment. We can look at the range of movement. And then we can start to work on towards some special tests, being realistic about what can be achieved on a video. We try to make it interesting for the patients as well and for our colleagues. And as I said, we're not trying to copy McLeod's. We're trying to get some of the same outcomes though. So when it came to our hip examination, we've got some guidance there on range of movement. What do the numbers mean? Because they're useful in a referral. And we've said to patients, we can say to patients, if you can try and make that number 4 there, or I sometimes say, if you've got the broadsheet newspaper and you're laying it on your lap to read it on a Sunday and you're crossing your knees, then we can do a kind of Faber test. There's a talk through here about how to do internal rotation and a kind of modified Faber test. And again, we're emphasising what we can't include in a video examination. We don't want to overemphasise special tests. That's unrealistic to achieve. And we're hoping for spine that we focus primarily on special questions, not special tests. And if we come to talking about ligament instability, we might need to bring the patient in face-to-face, but we're minimising the time that we share together in the room. We then went on to hands, trying to demonstrate the photo position. A simple photo with a Jupiter's referral can make all the difference. And then we keep the door very much open. The hearts and minds aspect of this is really important, and we want to keep it that it's very personal. So it's my own email address, and my colleague Gavin, his email address is there, and some recurring resources that we can share with GPs. So we disseminated the examination guide amongst our GP colleagues within primary care and within the surgical colleagues, but we wanted to maintain uptake and maintain enthusiasm. We shared it on social media and it's had several hundred downloads so far, and it was intended to be part of almost an altruistic approach of sharing our learning, sharing our mistakes so that other people don't have to. We've organised webinars, so this was our second one, as you can see in the yellow on the side there, shoulder. We timed them perfectly, I like to think, at 6:30 to capture those who were still at work and those who had time to go home from work as well. And we really were mindful of all the publicity saying, this is going to be 45 minutes. Your evening is not gone here. It's primarily about enjoying it and engaging those people who may not be interested. Including things like certificates and learning outcomes we thought was useful that people can refer to afterwards. And every time there's an update of the examination guide, we share it with that group of people primarily. We conducted the examinations with one doctor in one room, one in another, and we conducted it as though it was a consultation, constantly making reference to the guide and then having time for questions at the end. We had a spare person identifying any errors that we would make and then picking up any of the questions that appeared on Teams so that we minimised the clinicians' time spent at the webinar. We've given them positive feedback when they've included content from the examination guide. And when there's been a referral that's been deficient in its content, we've maybe said, here's the examination guide, why not try and use this just now? So we've tried to keep it very open, very positive, positively reinforcing what our colleagues are really trying to do with their best work. We want to increase the utility of remote examination across the musculoskeletal spectrum. I think spine is going to be difficult, but I can see a specific value in screening assessments in the first instance to ask specific questions, to tap into the mental health aspects of spine, as well as a gross assessment of movement and some of neurology. But we need to find the place for remote assessment going ahead. There was an initial flurry of interest in all our letters, and then it subsided a little bit. And I think, like, as we know happens so often, it's starting to find its place as an almost post-acceptance of referral appointment so that we can have a chat with the patient, maybe via Near Me, get some additional information as almost like a second triage that can, if necessary, turn into an appointment, and we organise scans from there. It'll be useful for us addressing the challenges of distance, and there's lots to look forward to us all going ahead. So thank you very much. I hope that's been interesting for you.
Thank you, Nafis. My name is Dermot Ferguson. I'm clinical specialist physio based up in the northeast of England. Nafis has asked me to speak today in relation to getting the best from an elective virtual spinal consultation to give a sort of more practical outlook on what's it like on the ground. Our trust is quite an expansive trust, and we're based from Newcastle all the way up to the Scottish border, so it takes about an hour and a half to 2 hours to travel by car around the trust. Because of this, we were an early implementer of the Attend Anywhere virtual consult program. We were able to access webcams and headsets quite quickly, and because of this, we changed our face-to-face clinics to virtual clinics after a few days playing around and practicing with each other in just a couple of days. Today's session is mainly drawn on information gathered by Lisa Roberts. The Talking to Talk is an excellent paper, Fraser Ferguson's Virtual Consults for AHP Scotland, and the Mayo Clinic proceedings. So what do we do? I mean, it's really, really important that you spend a little bit of time setting this up, going through all the stages for yourselves, but mainly for the patient so they understand what's going on. We use the Attend Anywhere personalized information. We've modified that slightly so the patient has some idea that this is not a Zoom call, this is a virtual consultation, this is a medical consultation, not a chat. So what I'll do is I'll just go through the process here as outlined by Lisa Roberts and give you some insight along the way. So we do the greeting. I'd say, hello, my name's Dermot Ferguson. I'm phoning you from North Tyneside Hospital. And I generally say, thank you for inviting me into your home, which lightens the atmosphere a little bit, gets a bit of a smile, and then we can move on from there. Say, thank you for inviting me into your home. Are you able to take the call at the moment? If they're in the car, obviously I'll say you need to pull over. We can do this subjective exam today, but otherwise we're going to have to reorganize. Then we can check the equipment. Can you hear me? Can you see me okay? Is the volume all right?
Thank you for
and remind them if
today
there's any problems
at the conference.
you
My
will
name's
contact them
Greg
by
Nichol,
phone, and
I'm a
it's
GP
sometimes worth just checking that you've got the right phone number. It's worth finding out what the remote experience is. Are they used to MS Teams? Do they TikTok the whole time? Get an idea, have you done this before? I generally say, look, these are interesting times, and we're all learning this together. Let's see how we get on. And that typically, again, lightens the mood a little bit. I do advise them that we'll be taking notes throughout the session. So if they hear the keyboard going or my head looking down, it's because I'm writing, not because I'm ignoring them. After that, again, you're going to do a preparation check. Are you ready for an examination? I am going to ask you to move. I am going to ask you to do some tests for us. And it's then and only then do you do the ID check. That preamble is quite good to do because it does work out any glitches. Patients are quite happy to tell you, oh, I can't hear you right there. Can you speak up? And you know, it gives you some insight there. One thing I would say to you as well is once you've clarified that they can see you fine, turn off your screen. What tends to happen is we tend to look at ourselves and we get focused in on that. And although we look great, it is all about the patient. So with this, we then go into the ID check. Could you tell me your name, date of birth, first line of your address is generally enough. You move then on to say your GP has referred you into me today for a specialist opinion. And then from there, you do that key question of, could you tell me your story? Could you tell me just a little bit about what's brought you to us? However you do that normally. And then shut up. We know that this golden minute where the patient informs you of what's going on, what's important to them, what their concerns and expectations are, what the issue is, it takes about 92 seconds on average for most patients. So it's very important at that stage just to nod and be quiet. Then you'll follow up with your standard TED questions. Tell me about this. Could you explain a little bit more about that? Could you describe to me? So that you can get more insight, as I said, on their issues, concerns, expectations of what do they want out of the consultation. Remember, active listening is really important here. Listening is not just waiting for an opportunity to speak. From there, you'll obviously do your red flags and special questions. These are typically closed questions. If you want to learn more about, what to say, what not to say, the National Back Pain Pathway has a session on Friday, and come join us in that. Okay, so from there, we move on to the actual assessment. And again, the important bit here is getting this set up right. Time spent on this is really useful. For spinal assessments, I found it quite useful to put it on a dining room chair and to have another dining room chair about 6 foot away, if that's possible. So that gives you an idea to see full profiles. People can move around on that. If the dining room chair doesn't work for them, it's actually better to put the phone on the floor, on the leg of the sofa or couch, so you can get a full aspect of the room. Now, one of the other added benefits for the clinician is that you can do these consultations in your shorts. So hopefully you can see full profile of myself here. This gives you a chance to ask the patient where are they feeling their symptoms. So they'll turn their back to them. Can you point to where it is? Is it coming down the buttock? Is it coming down the leg? From there, you're going to have an idea what their posture is. Could you stand to the side for me? Can you then go on to how they're moving and actually ask them how they feel when they move? You don't have the normal benefits of a face-to-face consultation where you can see their face and everything else. So do make sure, could you tell me how this feels? So they'll do their flexion, they can do their extension. Could you side bend to the left? Could you side bend to the right for me? And again, that gives you an idea from there. From there, we can assess their gait. What's it like to walk up and down? Obviously, I'm restricted here with my headset. What are they like toe walking? What are they like heel walking? If you feel there is an issue there and you want to check it, can they do their tandem gait? And if it's safe to do Romberg, then you can do Romberg. Again, that's helpful. If they have a chair there or they're beside the wall, it gives them that little bit of support that you know they're going to be safe. But even better if there's somebody with them. So palpation-wise, dermatomes, difficult to do. Again, with an assistant, it's better. But it is a case of you do the best you can. For muscle strength, you can do your squats, up and down. As I said, we've done your heel walking, you've done your toe walking. If you're unsure, you could do your unilateral heel raises. For reflexes, if you get them to sit down, and they can cross the leg, and I generally just ask them to use a book, or sometimes they can use their mobile phone, just to get them to relax. You can do that. If that doesn't work, ask them to put the heel on the floor. And again, you can see the response there. For your Achilles, quite good. Okay. For your plantar response, I ask them to use a pen and just face their foot towards the screen. From there, we go on to neural testing. What are they like sitting? They hold themselves steady, they lift their leg up. Tell me how that feels, where are your symptoms? Could you do that again for me? And then slump down. Again, giving you more insight as to what's happening and what the objective measures you can get from there. From there, we move on to the neck examination, which is a very similar setup. You'll find that the same rules apply. You're going to check their posture. You're going to check their range of movement of the shoulders. Have they got full range? From there, as I said, you could do your heel walking, toe walking, your dermatomes. If you are going to do dermatomes, you can do back of the hand. You'll work your way through C5, C6, C7, C8, T1. They could do that with a cotton ball or ice cube, or get something else to do it, because that actually generally is better. As far as muscle strength wise, you can ask them to use a bottle of water to see what their bicep curl is like, and they can do that side to side for comparison. If you feel they're up to it, you can do a triceps dip. Again, see how that is. You can do your grip strength and see how we are from there. Your reflexes, your biceps reflex, again, you do that quite well. Triceps is a little bit harder, but still possible. And again, gives you an idea from there. If we go face on, as I said, you can ask them to do their range of movement. Can you turn your head over your right shoulder? Can you turn your head over your left shoulder? What's it like looking down to the floor? What's it like looking up to the ceiling? Just talk me through how you're actually feeling there. We've talked about doing the plantar response. See if they have any sort of neurological changes there. We would heel toe walk and everything else from before. You can also have a go at doing Spurlings, where they look up and look to the side, put a bit of pressure through it, hold the 5-10 seconds. How does that feel? Okay, so as I said, that's all quite useful stuff, and you'll get a real good understanding of what's going on here. If you're concerned, you're going to organize to bring them in anyway. So moving on. Where do we go from there? So you've worked your way through. You've got down to your normal decisions, and then from there you're going to move on to the shared decision-making approach of what's going on here. Do you need to see them face to face? Do you need referral to physiotherapy, or what input are you going to do from there? When you are doing the shared decision, just make sure that you ask consent to share the information, to offer the advice. It's more important that you are that, how would you describe it? You know, the guide at the side, not the sage at the stage. You want to give them that information in such a way that they can understand it. Again, there's lots more to that, and you're experts in that anyway. Then from there, cap and wrap that up. So do your safety netting, your management, and then your next steps. It is a little bit more difficult to do closing statements in virtual. You know, closing consultation, normally you can give verbal cues and people are moving on. But a little bit harder in this situation. Lisa Roberts suggests doing the, was there something more you wanted to ask? And that sort of starts to close down the session, but also gives them the opportunity to ask stuff that they haven't thought of. Remember, when you are closing down, you know, give that positive last response of all the best, keep moving, keep active, we'll see you soon, or whatever. And then smile to the camera as you close. It feels really false, but as you're touching that leave button, keep the smile on, keep it goes, and then from there. Now, we have been using the Attend Anywhere program. We've managed loads of patients, and actually virtual consults do have some real benefits. Patients with long-term conditions with a lot of pain, it reduces the burden of commuting, which can be really exhausting, gives them energy, time and energy to focus on the consultation, not on the stresses of getting to and from you. Remember, patients are asking you to come into their home, so be kind, be nice, try and get some sort of insight on there. This platform is here to stay, and we will find it useful, I think, in the future. So we're ready for questions now, and we'll open it up to the floor.
So we've had quite a few questions, and there's one particular theme of questions which is based on the concept of recording of virtual consultations by patients, the medical legal side of that, and the data storage side of that. Alka and Gemma, from the Welsh side and Welsh technology, how was that addressed, please?
Thanks, Nafis. Not surprisingly, this came up very early on when we started rolling out video consultation, and it's going back to basics. We don't record every face-to-face consultation that we do. What is important is it's documented. It's documented in the clinical notes. And if there are good reasons to record, be it clinical reasons, be it for medical legal purposes, be it for training, that needs to be discussed with the patient. So that's from the clinician side. Patients can record consultations, but it's good practice to agree with the clinician beforehand that this is going to be recorded and it's for their personal use. So you don't want a patient to record it and then put it on social media. That would be inappropriate. GMC, MDU, MPS, professional bodies have now got clear guidance in terms of recording. There are indemnity structures in place from your health board trust, so it's worth checking with them. And there's very much out there in terms of what is doable, but good practice is document whatever you see, and if you've not written it, it's not happened. So there's.
Gemma, did you want to add something, and then Greg, please? We can't hear Gemma. Greg, do you want to jump in?
Yeah, can you hear me okay?
Yeah.
Yeah, I mean, certainly when we started doing video consultations, there were some instances, not locally, of patients recording consultations. We don't make a specific statement advising patients not to, because we felt that it didn't appear to be happening. We were no longer asking patients to do it. And everything that we were doing, we were regarding it that we would be functioning in the same ways that we would face-to-face, albeit within the constraints of a video consultation. So we've not made any special provision for the patients who might choose to record it.
Gemma, was there anything that you wanted to add?
I think she's having problems with her microphone.
No. In which case, if we can move on to the next theme of many of the questions which were put to us, which were about the actual success of the consultation itself. How many, or do you have an idea of the percentage of consultations which were virtual, which had to then be changed to a face-to-face? And how many of those were possibly because of the doctor and the patient preference? How many of your patients needed to attend an A&E department? And how many of the patients had misdiagnoses? Greg, do you want to start with that one?
I think a key point here really is that we didn't regard it as being that a patient had to attend face-to-face and that was a failure of a video appointment. We emphasised in the guide that we produced that it was an adjunct and it was a tool that should be used alongside face-to-face appointments. So when there was a video consultation performed, sometimes it was necessary to bring the patient in, but particularly during the peak of COVID, we were reducing the amount of time spent face-to-face. So we were getting our history, the introduction of an examination, and it might be that some of the special tests that require subtlety and palpation that can't be done by, is it sore to touch here? We're looking for hands-on examination. Those parts would be brought in, and we didn't regard that as being a failure of a video appointment, particularly when there were concerns about the time spent face-to-face with patients.
Alka, anything that you'd like to add?
No, again, we are capturing that data as it's emerging, and we have seen that, especially in primary care setting, very much what Greg was saying, it's a blended approach. Very often the conversation starts on the phone, and then it may switch off to a video consulting if the GP just wants to cast their eyes. Similarly, in secondary care, people do use, and that may be partly led by, the need for equipment or Wi-Fi connectivity at patient and clinician end. So it's not saying that we're going to replace everything we do face-to-face or by telephone by video consulting, but I think it's very much driven by what is clinically suitable and what is doable in the given circumstances.
There's another question on outcomes of virtual consultations versus outcomes of face-to-face consultations. And I know, Greg, one of the big themes that you had was to try and see whether you could improve consultation and pathways. Have you seen a change in the referral on process by using these virtual consultation tools?
Yes. Are you still hearing me okay? Earphones always seem to interrupt. Yeah, good. I think in the secondary care context, I would say one of the big changes that was quite surprising was how surgeons would accept a video consultation as being legitimate for someone being listed for surgery. So now that depends on the surgery. It's not all surgery, it's not all surgeons, but it was accepted that if a patient's been seeing a GP face-to-face or video, and then they have their remote consultation in secondary care, it's potentially possible to list them for surgery if it's unambiguous, if it is a 65-year-old plumber who's got a painful hip and an X-ray to back it up. There were grounds for doing that. So that was hugely efficient. I think in primary care, I'd have slightly more concerns because I'm worried that video consultation can potentially displace the important hands-on aspect of the GP role. I think that's part of what a GP does, and it's maybe not the most glamorous part of work, but when we're dealing with an overlap between physical and mental health problems, and I notice one of the questions mentions health inequity and health inequality, I would have big concerns there, particularly with regards to patients with learning disabilities, language barriers, these types of things, that these things can be overcome face-to-face, but can be more difficult on video. So there would be concern, not just that it's difficult to manage these appointments on the video, but these patients might see it as a disincentive to make contact in the first place if the mode of connection is likely to be a video.
Okay, thank you very much. I'm going to draw the session to a close and thank all the people who've attended and our 4 speakers. And I can see by the number of questions which have been posed in our chat that there's quite a few things that people would like to still ask and to explore. I'm going to invite you all to come into the chat room during the break session, and our speakers have very kindly said that they will stay in the chat room to take any further questions that you may all have. So I'd just like to show my appreciation to our speakers, and thank you all and enjoy the rest of the day. Thank you.